we'll get started with our cases. So our first case is a colitis case. It's a 23-year-old gentleman. He presented with 6 weeks of abdominal pain and bloody diarrhea. So initially he presented in November 2024. At that time he was having nausea, abdominal pain, but non-bloody diarrhea. And that's when he first presented to Lancet Hospital. He got a CT scan that showed pancolitis, and he was treated for presumed infectious colitis with antibiotics. He got discharged, his symptoms worsened, and then he started developing bloody diarrhea. He had more than 10 bowel movements daily. He came to the hospital again, had fever, tachycardia. This was confounded by being flu positive. Did have a hemoglobin of 4.7, albumin of 2.5. His infectious workup, stool infectious workup was negative. They did imaging, he had pancolitis. So they did a sigmoidoscopy on him, and what they noted was a mild ulcerative colitis involving the rectal and mucosal colonic mucosa up to the extent that they reached, which was 40 centimeters. In the past showed mild to moderate colitis and proctitis. It did note that there was no changes of chronicity in that pathology. There was no granulomas, viral inclusions, or any organisms that was identified.
Why was it called ulcerative colitis? There was no chronicity.
That was what they, in the mucosa, that's what they described it as when they saw it. But on the path, they said there was no.
It wasn't down here.
And then in terms of his past medical history, he has a history of pilonidal cyst, no family history of IBD or autoimmune disease. He's a master's student, he's a hunter, eats game meat. So going back to his hospital stay, he was started he was started on IV steroids, transferred to our hospital in January of 2025. At that time, he reported improvement of his symptoms with IV steroids. He actually got better. He was still having bloody diarrhea and urgency. His labs showed a CRP of 80 and a calpro more than 8,000. Albumin was 1.9. He got an MRE and MR pelvis because there was concern of a perianal fistula. He did have 1.7 centimeter left-sided gluteal inflammatory mass and faintly visualized perianal fistula. He had some upper GI symptoms, so he had an EGD that was normal. And then he had a colonoscopy that showed severe inflammation from the rectum to the ascending colon. His cecum and TI appeared to be normal. And you can see the pictures here with ulcerations throughout. And then for the pathology, give it up to Dr.
Too many words. A picture's worth, you know. Okay, so the upper left picture is a section from the duodenum. I can't even read it myself. Anyway, it was nearly normal. There was a comment about apoptotic bodies. I have to say the apoptotic bodies, my impression, were really not particularly, slightly increased, just so you know the baseline. In the small bowel, roughly up to 20% of their crypts can have at least one apoptotic body, and it's still within the normal range. And this was just slightly above. They're highlighted over there with the little red triangles. I don't think you can see it unless you're sitting right up front. The gastric, the next row shows the gastric mucosa, which showed some mild gastritis with a little focus of active inflammation in the center. And again, rare apoptotic bodies. Now, the stomach actually should not have apoptotic bodies, and a few were found. So there's something in the background. Frankly, I don't think the apoptotic bodies are the story. Here, let's go to the next one.
May I ask you?
Yes.
We hear this all the time, apoptotic bodies. So
Yeah.
what exactly are they? Are they like cells within macrophages? Are they like remnants of the nucleus within a macrophage?
That's karyorectic fragments. I mean, it's just the cells, you know, sort of dead and imploding.
It's dead.
You know, and they have different forms. Some of them look like, they call them popcorn bodies. Some of them just little fragments of nuclear debris.
So this is basically an epithelial cell.
It's an epithelial cell. That's correct. Yeah, it's a little gravestone there. But they do get ingested. They don't hang around much. They are taken away. Now the right colon, actually, you know, looking at your questions, this is sort of relevant. The right colonic biopsy shows an active chronic colitis. And we say that because there's a mononuclear infiltrate going from the surface all the way down to the base. But what I want to point out is on the right side, the crypts are quite distorted. You know, they're really a lot of disarray. Then in the center, there's an area of cryptitis. And then on the left, the crypts, also there's some inflammation, but they're very well preserved. They look parallel. And that's a little bit of a clue. On the lower panel, you see a crypt abscess on the left, and on the right, you see a mononuclear infiltrate. The fact that there are apoptotic bodies here is absolutely normal. There are no really good guidelines as to how many there should be. What we look for to call it really abnormal, what's so-called apoptopathy, which is usually related to drugs or other, we can discuss that later. That's where you get confluent apoptoses that are really disrupting the crypt. But what you see here is an inflammatory process. You have an inflammatory lesion with really the hallmarks of IBD. Now, the reason I pointed out the left versus right is because that's a little bit of a soft clue for Crohn's disease. In other words, it looks like you have a patchy, a non-uniform distribution of the architecture. I don't know if there are any more slides.
Right skewed. Right skewed or?
No, it could be anywhere. It's just
No, but in this
random.
case, it was more distortion on the right than on the
Oh,
left.
yeah. In fact, if you go to the next slide. So here you have a left side. Here there's another clue. So again, there's an active chronic colitis. The crypts are a little bit off. There's a heavy inflammatory infiltrate. But what I wanted to point out is that at the center of that submucosal lesion, which is impossible to make out over here, on the right side, you see on the bottom, there's a row of neutrophils. There's a band of neutrophils, and that indicates that there's either a submucosal abscess or a fistula. And when we see that, then it's sort of Crohn's disease until proven otherwise, unless you have very, very fulminant ulcerative colitis. But usually when we see that, it turns out to be Crohn's disease. So just jumping the gun, my impression was that this is probably Crohn's disease. Could be wrong. As far as the apoptotic bodies, I think it's a red herring. I don't know. How long before did he have the infection? It was not that long before these
We
biopsies.
don't have an infection.
Well, what they called
thought to
infection.
have.
Thought to have
November.
infection.
It was a month.
Right. So I don't know. I'm not sure. Was he taking NSAIDs or anything like that? There's all kinds of reasons to have a small number of apoptosis. I don't think one should pay much attention to.
That's very helpful. Thank
Okay.
you. So continuing his hospital course, the thought was he had IBD given his chronic colitis, so he started on infliximab.
And so, Thomas, there was an MRI done, there was nothing in the small bowel, huh?
Nothing in the small
Okay,
bowel.
so it's pure
With a-
colitis.
Yes. We did an MRE and an MR fistula. He had a small perianal fistula, but nothing in the small bowel.
Okay.
That is correct. So he was started on infliximab, given a second dose 3 days later. His therapy really did downtrend and he was doing well. Fortunately, we couldn't get him to feel well with steroids orally. So his symptoms recurred, his CRP went up, and then he was switched to upadacitinib, and he has been doing well since.
So he got 2 doses of infliximab and then never got a 3rd dose and went right to UPA. Okay.
And the second dose was high dose, I mean,
They were all 10 milligrams doses.
And the CRP before this was how?
It went down to 30, and then when he was switched, it went up to 110.
Maybe it was like 87 and then went, 87 or something.
I think this is very interesting. In 2016, there was a Nature paper from here, from Judy Blander's lab, who showed that these myeloid cells, like macrophages and all, will capture the epithelial cells that are undergoing apoptosis, and in normal circumstances, they will actually dampen the inflammatory response. But in situations where a person is prone to IBD, they will actually enhance the inflammatory response. So maybe there is something, and maybe there is, like a role played by other elements of the immune system here that may be contributing to
To
IBD.
his IBD.
So this may be the early stages of IBD in this individual.
so
where
early.
there is genetic predisposition.
The first biopsies showed no chronicity.
Yeah, those were not done here, so I really don't know.
You go back to the first time he presented at the outside hospital when, I just want to make a clinical point. When he presented with, I think his albumin was 2.5, and he was pretty sick, and fever, tachycardia, and they did the flexing, and they had mild inflammation. It is way more likely if they went above 40 centimeters, they would have started to see those deep ulcerations that you saw on the colonoscopy here. I don't think the sigmoidoscopy that was done there, they went far enough, because it doesn't explain an albumin of 2. You got to be pretty sick to have an albumin of 2.5. So he probably had much deeper ulcerations more proximally.
I fully agree with Jim. There is a discrepancy between the clinical symptoms, albumin, and the mild, right?
Right. They just didn't see it, and it makes more sense if you had Crohn's colitis. You just had deeper ulcerations further inland. So they just did some. You have to. Things have to make sense. When I was reading, I go, okay, this makes no sense. When I
Even
read the
though,
first.
Jim, the next endoscopy, if you can show the
Yeah,
picture,
that
this
here-
really looks like, I don't know. I mean,
But it may have progressed.
Here, right, but here it's, you don't even have to go in. I mean, you go in and you're done. 10, 15 centimeters, you've seen enough. So, oh, it's terrible, right?
Definitely multiple surgeries. Those are very good points. Thank you. So I think we talked about some of the questions, but what is your differential for your presentation? How many of you think this is IBD and would treat as IBD, or how many of you would ask for additional workup or think of other reasons based on the path results or his presentation?
so I don't know.
And I know
The presentation is entirely consistent with new onset of IBD. It's not specifically Crohn's or UC, but there are some hints. The apoptotic bodies are a red herring. They're a distraction.
And I think there was a comment from Pat. This could be sometimes associated with other diseases like graft versus host disease, right? No,
It was mentioned on the report,
yeah, right.
but it's out of context.
Context
When
was
it's-
wrong.
No, I
Context
know,
was
but
off.
I'm just saying.
Yeah, there are a lot of situations where you can see apoptotic bodies. I mean, we actually count them for patients who are having, rejection after small bowel transplant or GVHD and things like that. But other than that, I think somebody noticed it and then they started getting all focused on
I
it.
think there is a question from Peter and David.
Dr.
I just wondered whether any other agents were considered to switch. Why was that the switch that was made to the Rinvoq?
That was mainly because he was inpatient and we wanted an agent that worked fast because we couldn't get him off IV steroids.
He had acute severe colitis, Peter.
Yeah.
Not fully
Okay,
responsive
and
to
you didn't have any
infliximab.
trouble getting that? It was here, you had samples or it was there?
No. What happens is it's
You need to call Bruce and that's
yeah.
it.
Don't call. Send me an email. It's not on formulary, but we're really talking about a few pills, so it's not going to break the bank. And essentially, you email me, I will approve it.
And he say yes.
Yes.
I don't think you would consider any other agents in this clinical scenario anyway. I think you go infliximab and then UPA. I don't
Maybe in
think
the past you will have considered cyclosporin.
Right. Yeah, but we don't have to. Thank
We
God
may
for
never
that
see that
anymore.
used ever again.
Dr.
David?
David,
You had a comment?
you are muted,
Muted.
David.
No.
Still muted.
Still muted.
It's a little unusual to catch idiopathic ulcerative colitis early, such early stages. In the first few weeks that you haven't yet gotten the architectural distortion and
But you have.
changes of chronicity. But it does take a few weeks, maybe 4 weeks or so, before you actually see those histological changes. One of the questions I had in the differential diagnosis between an acute idiopathic self-limited colitis, which this is not, and idiopathic ulcerative or Crohn's colitis, where were the polymorphonucleocytes in the biopsies, in the subsequent biopsies? Were they scattered throughout the lamina propria, or were they primarily adherent to the crypts? I have found that's very useful in the differential diagnosis between
David's asking me.
colitis
Yes.
true
No,
chronic IBD.
It showed the appropriate distribution where the neutrophils are attracted to the epithelial components and somewhat less represented in the lamina propria. Okay, and as far as the time course, I mean, we all know that if you biopsy patients with acute onset of UC, you see changes there that clearly were there for a while, for months perhaps. And that's the symptoms don't often correlate with the actual onset.
When we hear about intraepithelial apoptotic bodies, I mean, commonly that we see that reported in graft versus host disease or medication-induced, such as checkpoint inhibitors, MMF, and things like that. And sometimes when you think about checkpoint inhibitor in colitis, we often hearken to it as like the incipient IBD, or like the a model where you see IBD develop. So perhaps that's what we're seeing in this case as well. We're just catching it, the changes a little early.
Well, I mean, we checked. I don't think he was on anything that would have caused that. No, the apoptotic, it was really not significant.
So I would respectfully disagree. I'm sorry. Whose patient is this, first of all?
He's one inpatient.
He's still in the house?
No.
This is so exciting because this is how I'm viewing this, and this could be a completely biased perspective. This guy has colonic inflammation, likely Crohn's disease. We are finding people with colonic Crohn's disease and ulcerative colitis to be positive for this new autoantibody, alpha V beta 6, which is targeted to the epithelium. So it binds to an epithelial protein called alpha V beta 6, which is important in maintaining homeostasis. And that potentially could be related to a downstream immune-mediated injury, which could be killing the epithelial cells and producing some of these, apoptotic bodies. And it could be also associated with tracking of neutrophils to the epithelium. So in fact, we think that neutrophils, through extracellular trap formation, are probably implicated in the development of these antibodies. We've not proven it, we are looking into it. So we would be very interested in testing if this patient is positive for alpha V beta 6.
He follows up with Dr. Person now.
Okay, so we would be
Which part do you respectfully disagree with?
the fact that apoptotic bodies are red herring.
Oh, okay.
Oh,
Okay. All right.
diagnostically.
Red herring means it is falsely leading you to some other diagnosis. So it is a red herring if you consider it means some other diagnosis. But anyhow.
No. Apoptotic bodies could be a feature of IBD. We just
Yes.
don't
It's
regard
just
it.
that when people see that, they think it's not IBD.
Yeah, right. And actually, this was the confusion in that case.
Yes.
So I think everyone agrees here that this is IBD.
Yeah.
The question is if this is UC or Crohn's. It seems like it's more Crohn's.
Well, Sergey doesn't think he had perirectal disease.
He does not. He does not. I saw him in the hospital. I saw both of his MRIs. He does not have perineal disease. He definitely has pilonidal sinus.
Dr. Kaifan, can I have you expand on that a little for our audience? On how would you differentiate and what do you look for?
I mean, pilonidal sinus is pilonidal sinus. It's which he does have, and he has pilonidal sinus. It's like a very, very simple thing to see. On rare occasions, we do see connection between pilonidal sinus to anus, but that's kind of exemption. It's very, very unusual case. Something like that you would typically see on MRI. Now, his first MRI, there is vague signal which they barely describe as a fistula. He does not have evidence of perineal disease on examination. And on second MRI, they describe nothing. There is nothing. So it's tough to call perineal disease. Now, that does not mean at all that he does or does not have Crohn's colitis. That time will show. That's the point. And during his hospitalization, we kind of agreed that Remicade was probably good for either one. That was the impression from surgical perspective.
Right.
And same for upadacitinib.
Yeah, it's sometimes it's just impossible to distinguish between severe Crohn's colitis and severe UC. It's just
With an acute presentation,
Yeah.
yes.
I think we talked about this and we talked about all of this.
I recommend alpha V beta 6.
What about an ASCA? Would an ASCA be helpful to differentiate? I'm asking the inventor of ASCA.
No.
No.
And Pianka.
Pianka, no.
Yeah.